Hey guys, John Adamson, the Rehab and Documentation Guru. Did you ever have one of those visits with a patient where you thought, what the heck am I going to do with this patient? Or you thought, somebody's missing something here. I had one of those today. So I got a referral for a patient with COPD. And nurse was out the other day, did the assessment, case opening, and I went into his home today. Let's just say he's elderly, but not that far into the elderly spectrum. Let's just say he's below the average life expectancy for a male, but he's of retirement age. That'll give you a ballpark of what we're looking at. He comes walking in, no shirt on, barefoot, oxygen tube trailing behind him, no device. Sits down in front of me, and I look at him, and I'm immediately like, I'm not going to be able to rehabilitate this guy. He was rail thin. And I did a BMI calculation of this guy, 17.79. Now, just for reference, what's considered normal weight is between 18.5 to 25 on the BMI scale. If you're in that range, you're considered normal. Of course, some people are going to predominantly be towards the lower end. Some might be closer to the higher end, depending on your body type. But at 17.79, this guy has cachexia, or a generalized wasting of the body. I look at him, and I can see his pectoralis minor. He's got practically no pec major. I can see the fact that with his breathing, he's got paroxysmal excursion of his diaphragm. Now, what does that mean? That means when he breathes in, his diaphragm, or I should say when his diaphragm contracts, his ribs actually retract, and when he relaxes, they expand. What is that a sign of? Significant flattening of the diaphragm. The diaphragm is no longer dome-shaped. Normally when you breathe in, the diaphragm contracts, opens up the lungs, the ribs expand. But when you've got advanced COPD, end-stage COPD, this time when the diaphragm, because it's flattened, contracts, it brings the ribs actually in. So his breathing pattern was paroxysmal. It was the reverse of what should be going on. So he's respirating at a real high rate. He's on 3 liters, which is kind of high for a COPD patient. And he tells me he's bumping it up on occasion. Still smoking a little bit, but he's trying to quit. I mean, he's a nice guy. Definitely high anxiety, looks harried. Anyway, having experience with working with all 3 disciplines, I started asking him some speech therapy related stuff. I asked him, first of all, how much weight had he lost recently? And apparently he's lost about 70 pounds over 2 years. And that's about as long as he's been dealing with like the end result of his disease. So I said, I bet you're not eating very much. And he said, yeah, I can hardly eat, and I feel full, and it makes me have it's hard for me to breathe. And I said, I bet you're having a hard time coordinating your breathing with your swallowing. And he said, yeah, I am. I choke and I cough sometimes when I'm eating. So there you have it. He's nutritionally deficient. I said, are you doing any boost or anything like that? Yeah, I'm trying to do that. And so anyway, he's just not getting enough calories. So with that said, even if his lungs weren't in such bad shape, and he wasn't already just using energy just to sit there and talk to me, I wouldn't have a basis physiologically to build muscle because the guy doesn't have sufficient caloric intake. He looks like a Japanese prisoner of war camp victim from World War II. I mean, one of our soldiers coming out of Japanese prisoner of war camps or Holocaust. Not quite that bad, but getting there. Very thin, bony prominences showing everywhere. And this used to be a fairly sizable man, according to him. So, anyway, oh, here's another thing. He starts telling me all these different symptoms he's got. First of all, I noticed his blood pressure is pretty darn low. Two, he's obviously in a chronic state of anxiety. Three, he's chronically fatigued. Four, he's got limited appetite. Generalized muscle wasting. What are those a sign of? Adrenal insufficiency. And as an end-stage patient, he's on 10 milligrams per day of prednisone, which is a very low dose. And I understand, generally, the use of prednisone, cortisone, things like that, you got to be a little bit careful about, putting people on that. But when you're at the end stage and you show signs of adrenal insufficiency and you're having massive problems breathing, he's probably being undertreated for that. So what I did was, one, I requested a speech therapy consult. Two, I'm only going to follow up with one time because in addition to some problems with his strength and getting around related to balance and strength, I'm not going to be able to address that. So I'm going to just try to get him a four-wheeled walker and show him how to use it. Show him some very easy range of motion exercises to just try to keep a basis going so he doesn't lose too much muscle and he's got good range. And that's going to be about it for me. And then three, I just prodded the nurse gently to say, hey, here's his signs and symptoms consistent with, I forget how I worded it. I tried to be careful because, boy, it sounded like a diagnosis. Tell me if you think this sounds okay. He is demonstrating some of the common signs and symptoms of low adrenal function. I think that's safe to say it that way. And I just put them down, which all related to that. And I pointed out that he's only on 10 milligrams. I said, I noted that the patient is on 10 milligrams prednisone per day. So I didn't say it's too low, nothing like that. Just said, this is what he's on. This is what he's demonstrating, consistent with low adrenal function. And then I just put, do you think it's worth discussing with the MD based upon his dosage? So I just left it like that. Actually, I'm going to take out based upon his dosage while I'm talking about it. Because I want this nurse to think medically. And I'm not saying nurses don't think medically, but I think sometimes they're too quick to just follow what the doctor's saying. They've got training in what these medicines do, and they do education about the meds, but some of them don't give feedback to the doctor like, hey, doctor who has only seen this patient for 5 minutes in the last 90 days, what do you think about this? And see what the doctor says from there. Anyway, that's how I'm handling this particular case. Any comments? I'd appreciate them. What would you do? How would you handle this guy? He's a challenging guy, and I'll tell you one other thing I mentioned to him. I said, has anybody ever talked to you about hospice? And he goes, oh, well, hospice kind of scares me. And I said, I understand. I said, if you're willing, I could just have somebody explain the program to you, and you can say no to it. I just left it like that. I'm not prescribing it. We have been told as an agency to, if we want to bring it up with the patient, have you ever considered, has the doctor ever talked about, and then just put it in the patient's lap and say, do you want some education about this? Because it's pretty clear this guy should probably be on hospice, unfortunately. But maybe with a little change in medical management, maybe a little bit extra prednisone, maybe a little speech therapy, maybe he'll build up a little bit and have a better quality of life going forward. I don't know. I'm hopeful. Anyway, John Adamson, the rehab and documentation guru, hoping you're having a great Monday. Take care of yourself and God bless.